So nursing considerations in managing prostate cancer. We'll be talking about what prostate cancer looks like, the overview of the disease state, and some key clinical evidence, and we're going to show it with patient cases. So you sort of can put it in perspective to an actual patient that you might be seeing in your clinic and having to make treatment decisions on. So we will talk about non-metastatic castrate-sensitive prostate cancer, which is a very common patient in urology clinics, PSA relapse after surgery or even after radiation, et cetera. And then we'll be talking about metastatic disease, because as these patients get metastases, they are still typically being seen in a urology office. We'll talk about castrate-resistant prostate cancer, non-metastatic, which means when they've started to have their PSA start going up, even after they've been on hormone therapy. And then we'll be talking about metastatic castrate-resistant prostate cancer, one of the biggest challenges in advanced prostate cancer treatment. And we'll talk about how that multidisciplinary collaboration should work. So starting with an epidemiology, prostate cancer is the most common disease in American men, most common cancer. About 30% of new cancer cases in men are prostate cancer. So what we saw from the prostate cancer prevention trial is that if you biopsy and do screening procedures, 1 in 4 men will be diagnosed with prostate cancer. If they're about the age of 50, you're doing an annual PSA. Now, within that, there are about half of them are clinically relevant prostate cancers, which means they need treatment. They're likely to go on to get metastases in the patient's lifetime. Now, in African Americans, there is a much higher incidence. So I would say about twofold increased incidence in African Americans as compared to the average other Americans with prostate cancer, and there has been a higher mortality seen. But what we do know now more and more, that if they get access to the right treatment, their survival and their overall outcome can be the exact same as any other person with prostate cancer. Median age, this is a disease of the elderly. Median age at diagnosis is about 68. And clearly, we all have those patients in our clinic, 80 plus, 90 plus, who have prostate cancer. And they raise a separate dilemma, because you're always wondering about the risk-benefit ratio of different treatments in them. 11% of estimated cancer deaths in men are from prostate cancer, so don't let anybody tell you that prostate cancer does not kill. It sure does. Metastatic castrate-resistant prostate cancer can be a very morbid condition with the bone pain, with the neuropathic compression, et cetera, and the possibility, of course, of mortality. So age incidence, of course, it rises after age 40. Those young patients, you should be specially paying attention to if patients have a family history, or if they have history of BRCA1, BRCA2 mutations within their family with breast cancers, ovarian cancer. Frequently, patients will not make the connection. They will never think of telling you that, their mom had prostate cancer, or their mom had breast cancer, or their sister had ovarian cancer, and, whether that could be genetically connected. Well, it absolutely is. So that is something. I had a patient for years who never told me, until I met his daughter, she had had a bilateral mastectomy because she had BRCA1 mutation. And, the crazy thing is the patient kept saying, no, I have nobody in the family who has cancer. And so just now it is important in this era of genomics to sort of push a little deeper about the family history. So 5-year survival rate for early localized disease. Clearly, if you find them early enough, long-term, 5 years is sort of a short-term follow-up for prostate cancer. As I said, you're in it for the long haul, but 5-year survival rate is almost 100%, 80-90% cure rate in those early-stage disease patients, but then 5-year survival rate, once they get metastatic, once they have PSA relapse, rapid PSA doubling times, the rate drops to about 30%. So this is a heterogeneous disease that does require personalized care because you're dealing with an elderly patient population. Frequently, they have multiple other comorbidities that you have to take into account when you're considering treatment. So the heterogeneity of prostate cancer makes the patient management somewhat challenging. There's a wide spectrum. It can go from aggressive to very, very slow growing. Sometimes the slow growing can change, so monitoring is also key. And 30 to 40% of patients, what population studies, SEER data, et cetera, shows us that are not getting optimal treatment, and maybe that's an underestimation, and they are either over or undertreated. So bottom line, improving individualized care in prostate cancer is a big unmet need. Whom to treat, when to treat, and what is the best treatment? Also, I would add to that now how long to treat. If patients, it's a good problem to have because if patients are going to go longer term, even with metastatic disease now, with the better and better treatments we have, maybe we do need to think about, do I stop treatment after 2 years, monitor them closely, select out the patients who we can do that for. So these are the clinical states of prostate cancer. Clearly, the clinically localized disease is where you first typically see the patient, at least in a urology office, where you're biopsying, sending the patients for a biopsy, or the primary care physician has seen that there is an elevated PSA and has referred the patient for consideration of biopsy, et cetera. Then there is the PSA recurrence. So after you've done surgery or sent the patient for radiation, whatever it may be, if the typical way you're going to monitor this patient is by PSA. And usually after surgery, in prostate cancer, your PSA should be undetectable. However, once it starts going up, there are different pathways of how we tackle those patient population. Then moving on to the non-metastatic and metastatic. Metastatic is where on conventional imaging and not the PSMA PET scan, that is not included so far in our definition of metastatic disease. We talk about if we see mets on a CAT scan or a bone scan, that is to this day at least considered metastatic prostate cancer. There is a new definition for oligometastatic prostate cancer. So when you have a PSA that is fairly low, 0.5 or higher, usually you would do a PSMA PET scan trying to detect early metastases. And that is if you find 3 to 5 mets or less is considered oligometastatic state, and that can be handled with stereotactic radiation, very focused radiation to those areas, things like that. So that is the nuance of this new state that is evolving. Unfortunately, what we don't have is long-term follow-up for this. PSMA PET scan and all that has been probably available for the last 2 to 3 years. So these are the different clinical states and the definitions, and you have those up there. I won't go through each and every one, but I think bottom line, rising PSA would mean that you need to typically get some imaging. Do not react to just one PSA. If the PSA goes, and patients are tuned into, the moment they see any change in that number, they're like panicking already. And it's your job to sort of reassure them and say, let's not jump to too many conclusions just based on one PSA. At least do one more repeat one like a month or a few weeks later to see where they stand. And if it's truly continuing to rise, then you at least have confirmation and then move on to your workup. So typically, the rising PSA pattern will decide, and then you go back and look. Was there positive margins? Was there, what their Gleason score was? So that the Gleason score tells us how aggressive the prostate cancer is, and then you make a decision. If it was rapidly aggressive, the PSA is going from 0.1 to 2 to 5 within 3 months, then you have a problem. You usually need systemic therapy, which means treatment like hormone therapy would be systemic, which goes through all their system and controls the cancer.